Hello to those joining us. We're going to give it a moment or two for everyone to join us. I know there's lots going on this time of year. We're very happy to see those who are able to join us live today. I also know we'll have folks view the recording. If you'd like to introduce yourself in the chat, feel free. We love to know where folks are coming from. As you can see, we have a few of our staff giving welcomes in the chat. And yes, since it's a webinar, you have options to utilize the chat box or the Q&A feature. We have a couple of fantastic panelists today, and I'm sure folks will have questions about their programming. So again, we're happy you're here. For the sake of time, we will get started, but I know we'll have folks continue to join us. So again, hello and welcome to this webinar on addressing social isolation and loneliness in older adults living in public housing. This webinar is a joint effort between the National Center for Health and Public Housing and the National Center for Equitable Care for Elders. My name is Ariel Mather, and I'm the program manager for NCECE, and I'm joined by my colleague, Dr. Kevin Lombardi from NCHPH. So you'll hear a little bit more about our organizations in a moment, and I'll hand it over to Dr. Lombardi to do just that.
Good afternoon, everyone. Thank you for your time and thank you for your service of this demographic. To briefly go over our mission, the Center for Health and Public Housing exists to strengthen the capacity of public primary care grantees and health center grantees that are in the immediate vicinity of public housing through technical assistance. And CPH is a project supported by the Health Resources and Service Administration, a national training and technical assistance partner, and is 100% financed by this grant. Next slide, please.
Great. And for our center, we are also a national training and technical assistance provider. We are focused on the health and well-being of community-dwelling older adults. We have lots of ways to stay connected with us linked on this slide. It is our center that you have received any reminder emails from. We will be following up afterwards with emails from our center just for context, but we'd love for you to check out any of our future training and technical assistance offerings as we are hopeful in the new year that you'll be able to see a lot of great training offerings around, again, the health and well-being of older adults. I always like to plug the Health Center Resource Clearinghouse in any of our activities, as it's a great one-stop shop for information around anything related to health centers and patient care. So if you haven't already accessed the clearinghouse, feel free to do that within the link in the slides. I know that folks usually have questions. Just as a reminder that all the slides and the recording will be made available to everyone who registered. You'll get that in your email. So the Zoom reminders that we're very familiar with at this point, all lines are muted just to prevent background noise, but we really would love to hear from you. You have options through the Q&A feature and the chat box. If you have questions for either myself, Dr. Lombardi, or our wonderful panelists, we'd love to hear them. We have a good amount of time at the end of this session for Q&A, so feel free to offer up questions, or if you have services or programs that you want to highlight that address social isolation and loneliness in this population, we'd love to hear about those as well. So again, yes, everything's being recorded. Materials will be made available after this session. And when you close out of the Zoom today, as well as you'll see in your email, you'll have the chance to give feedback in an evaluation link. Takes really just a minute or two, and your feedback's so valuable, it helps to shape future trainings. So please consider filling that out. So you've seen the learning objectives. Sorry, I'm just looking in the chat. Yes, we will make sure that everyone in who's here today gets all of that information. So you've seen these learning objectives as you signed up for this session, but we're hoping you'll walk away from this webinar really understanding the particular disparities and health concerns related to older public housing residents when it comes to the experiences of social isolation and loneliness. We'll talk a little bit about screening and documenting these concerns in a health center context, and then hear about some strategies for increasing social connectedness For these public housing residents, we'll hear from two panelists again who have distinctly different programs, and I think we'll learn a lot from their experiences. So jumping right into some level setting content. So myself and Dr. Lombardi are going to take the next 20 minutes or so to dive into some information to make sure we're all on the same page about this important topic. We really should start, if we're talking about older adults, to really mention and highlight the growth of the older adult population. Older adults are the fastest growing demographic in our country. You can see in 2019, 54 million people were over the age of 65, accounting for about 16.5% of the total population. But by 2050, that figure is expected to increase by 22%, meaning that nearly 1 out of every 4 Americans will be over the age of 65. We do want to certainly mention that this population is really diverse and complex, so there's no one image or description that fits folks over the age of 65. As I'm sure you've seen with many of your patients, some older adults are very active in their communities, in their jobs, or roles as family caregivers. Others may require further degrees of assistance for themselves to effectively manage their health. That's really where health centers come in. You can see this graphic from NAC's Community Health Center chart book. We see that, of course, the percentage of older adult patients in community health centers has really also grown exponentially, with those over the age of 65 increasing by 120% between 2010 and 2020. Health centers are really well positioned to address social isolation and loneliness through assessment, through referrals to both local and national organizations that provide opportunities for connection.
Housing is a human right and has an unstatably important impact on health and well-being. Here's some figures just to show the size of this population and the magnitude that they have on our health system. This data shows 30 million patients see federally qualified health centers, and of that, 458 are immediately accessible to public housing patients. This is a large population with significant needs. Thank you. In some more detail on the demographics of our housing, our population, 52% white, 48% African American, and 26% Latinx. And interestingly, 32% are female-headed households. Thank you.
Yeah, and we see 19%, at least at the time of this graphic, are 65 or older. So very relevant to have both of our populations focused on today. So we know that we're talking about social isolation and loneliness, but we do want to make sure we're on the same page about what those two terms mean. You see some basic definitions on this slide. Generally, we can think of social isolation being defined as having infrequent social interactions with others. A more nuanced definition might be one that accounts for cultural differences, subjective perceptions, really seeing it more as a lack of desired connection with others, resulting in a sense of being disconnected. We should understand that social isolation is often situational. Older health center patients often rely on places outside of the home for social interaction, whether that's day programs, community programs, libraries, cafes, places of worship. But when we're talking about loneliness, that's going to be a little bit less structural and more subjective. So someone can be alone and not feel lonely, or conversely, they could be surrounded by other people, yet still feel lonely. So they're not the exact same thing. So it's important to note that we're talking about both of these things. We will talk more about the report that is linked at the bottom of the slide, but there's a consensus study report around social isolation and loneliness that really helps to unpack both of these terms, but we're starting with the basics here to make sure we're on the same page. So wanting to note that the concept of social isolation and loneliness, I think, has been talked about a lot more since we've been in the COVID-19 pandemic now for maybe several years. But I want to note that even before COVID-19, loneliness was seen as an epidemic. US Surgeon General declared loneliness as a public health crisis years before we even knew about COVID-19. I won't read you this long quote, but it's really focusing on the broader population, though it's still very relevant for older adults. The National Institute on Aging says that the health risks of prolonged isolation are equivalent to smoking 15 cigarettes a day, which is a stat that's been around for a while, but I think it's really impactful to see the health effects of social isolation and loneliness. So again, we're talking here in this quote about the population as a whole. We do want to be mindful of the physical and mental health impacts these experiences have on individuals of any age. I think culturally, we have a little bit more empathy now after going through, whether it's required or voluntary lockdown, socially isolating ourselves the past few years, but we want to make sure we're still keeping this concern at the top of our minds for this older adult population as we move forward. So like we said, the health effects of social isolation and loneliness can be significant. We see here this concept of a bidirectional relationship, how these things can interact with these experiences of social isolation and loneliness. The health impacts can be both direct and indirect. So if that's physical changes, could be increased inflammation, a heightened stress response, perhaps impaired immune system functioning. We might also see an indirect impact if that's related to negative health behaviors. So if we're not getting enough physical activity because of how we're feeling, poor nutrition, impaired sleep. Again, direct, indirect impacts here. We'll talk about some of these in a little bit more detail when we discuss chronic conditions, but you see both physical and mental health effects, ultimately also seeing at the end of this list the risk of premature death. So there's a resource linked in this slide that's a little bit more focused on behavioral health, suicidal ideation in this population. That is certainly a helpful resource. So other special considerations, again, the impact physically and mentally of social isolation and loneliness is of concern for someone of any age, but we're talking here about adults over the age of 65. We'll actually see for one of our panelists, we're talking about a little bit broader of a group, so 55 and older, but we are talking about older residents of public housing here, so some special considerations for us to keep in mind. We'll talk more about chronic conditions, I think, on the next slide, but certainly this is something that many older adults are living with more than one. When it comes to life transitions, certain ones may increase the risk for experiencing social isolation and loneliness. That could be experiencing a serious illness, changes in mobility, experiences of family caregiving, either being dependent on a caregiver or needing to caregive for another person. Changes in income or retirement is a major life transition that can have an impact on these experiences. Potentially losing a loved one, moving from home to another location, or needing assistance in the home. We also want to note certainly sensory impairments like hearing loss, vision changes can also limit the ability of older adults to maintain connections with their community. We know certainly transportation is a significant social determinant of health, and that can really reduce engagement and increase social isolation, particularly in this population. If older adults are no longer driving, if they're making fewer trips out to shop, to see friends, family, transportation in general can also impact health outcomes, as we know for older adults, as many adults over the age of 65 live in car-dependent communities. We'll hear from a health center that's a little bit more urban, so there still could be concerns with public transportation. If that's the case, they may make fewer trips to their primary care provider as well.
As a general internist, the majority of the patients I treat are older adults. And this is a population that's uniquely challenging to treat clinically. due to the many chronic conditions and many medications that they often take, but also due to the complexity of their life transitions and social situations. Data shows that approximately 85% of older adults have at least one chronic health condition, and 60% have at least two chronic conditions. For those of you who practice clinically, I'm sure you see quite a few patients that have many more than two conditions and often need to manage very long lists of medications. These are complex, confusing, and have some pretty significant impacts on their daily lives. The impact of chronic conditions on the daily lives of adults are significant and can impact social isolation and lead to loneliness in some very real ways. Conditions that are particularly common in this demographic, such as COPD, CHF, degenerative chronic pain conditions such as rheumatoid arthritis, sciatica, and osteoarthritis, are often comorbid and have cumulative effects on mobility, mental health, and isolation. In addition to the conditions themselves, many of the common medications that are taken for these conditions, such as diuretics, opioid analgesics, and beta blockers, can lead to limitations in mobility. For example, those that take many loop diuretics, ACE inhibitors, and so forth, often have frequent urination, and for that reason will tend not to go outside or can be embarrassed to get out into their communities, leading to isolation and fear. And also fear of falling, in particular for those who take medications such as beta blockers and opioid analgesics. There could be a very real fear of falling that stops people from interacting with their communities and limits their social interaction. In addition, dementia and other types of neurocognitive decline are very common in this demographic. And some of the medications used to treat those can have significant effects on personality and mood. For example, second and third generation antipsychotics are often prescribed to this demographic at lower doses. These can lead to those changes in personality and mood that may strain social relationships. And a reminder that these effects are cumulative and can exacerbate social isolation and lead to loneliness. A couple of reflection questions to consider. One, the most chronic health conditions in older adults. What do you see and how does it impact them? And some of the other social determinants and demographic effects that impact social isolation. These can work cumulatively and can have a significant effect on social isolation and lead to loneliness. Next, please. To briefly go over a couple of screening tools that I've used clinically that I've found particularly helpful in treating this demographic and elucidating the details of their social context. You may be aware of the Prepare tool. It's an effective way to understand the baseline SDOH factors that impact a patient, and it can give a particular insight into this population. But with some caveats. Using screening tools with older adults can be challenging. Older adults, especially those who live alone, can be very protective of their independence. And older adults who are experiencing or at risk of experiencing social isolation are often very effective at telling providers that they're doing fine. And being able to detect this is difficult, and screening tools are an important way of standardizing that process in a way that's objective and allows better insight into patients' lives. Of importance with these tools is knowing when to involve family members or other social contexts to verify the information. Older adults are often very protective of their independence and may alter or sharpen their answers to make it seem like they may not be at risk for things that they are at risk for. It's important to understand at this time that it may be appropriate to get supporting information from friends and family when possible. But if the patient is capable of making their own medical decisions, it's critical to ask that permission before doing so. Another reason why your clinical and social relationship with the patient is particularly important. Next slide, please. The mini mental status tool is something I hope those of you who practice clinically use regularly in your own practice. This is a good tool because it both standardizes the evaluation and it leads to some pretty important insights, in particular about mental status, cognitive decline, two things that lead to both social isolation and can lead to loneliness. Older adults experiencing neurocognitive decline are at increased risk of social isolation. And in clinical interactions, the MMSE should be performed in older adults who are at that risk. Of note, again, older adults experiencing the early stages of neurocognitive decline are often very deft at answering these questions. The reason I like this tool is it's very difficult to navigate for someone who's trying to navigate it. And it's an appropriate way to measure and intervene when appropriate. The screening tools. Ariel, did you want to speak briefly about this?
Yep. Sure. So I mentioned briefly in an earlier slide, we had linked this consensus study report from the National Academy of Sciences, Engineering, and Medicine. This came out in early 2020, once we were starting the pandemic, but really obviously all of the information was prepared before it. So it was very, very timely around social isolation and loneliness in older adults. Really extensive resource. You can see in this screenshot that you can purchase it, but it's available for free download. So I encourage you to go that route. There's a specific link, and I believe Juliet put, thank you, in the chat. There's a specific chapter around assessment. And to Dr. Lombardi's point, and I think we'll hear a little bit from our panelists as well, navigating the assessment and documentation of this type of concern, there's a lot of ways to do it. And there's sometimes the less formal is better, depending on relationships and the amount of resources and support available within the health center context. I'll say that this chapter is really fantastic with summarizing the tools that have been around either for decades or have been developed more recently to assess, and they note both which are intended to use in a more research setting, academic setting, versus a healthcare provider setting. So really important to note that not all the assessment tools will be relevant for health centers, but it's a really great quick look at what tools are kind of recommended overall or what have been used historically, and of course, lots of other chapters of relevant information. Instead of taking the time to go through in a lot of detail the various screening tools, this is going to be a really individualized choice for health centers and other settings to explore whether this is feasible or not. So to Dr. Lombardi's point, the PREPARE tool is a general SDOH risk factor screener that does touch on elements of stress, relationships, socially, so you might get a little bit of an idea of where someone's coming from. But if you do decide, oh, with certain parts of our patient population, we do want to explore this more in depth, knowing the health impacts of social isolation, there's a few questions here that Juliet linked the original resource that we've based these questions off of, that I think this is more valuable for us to look at briefly together than, again, looking through a list of potential screening tools. So really understanding how comfortable you are talking about loneliness and social isolation with a patient. It's not necessarily the most comfortable topic. It really taps into maybe some difficult experiences that the older patient is having, especially if they are in a season with a lot of different life transitions or serious illnesses that they're navigating. So how comfortable are you is a great starting question. Time is the second question, and we know so often health centers don't have a lot of it. So if, knowing how much time you have to interact with patients, the third question kind of ties into that. Who is the one asking the questions or would be the one asking the questions? If you do use such a tool, that's going to give you a lot of information on whether you're using a 2-question screener or something more in depth. Where can this type of screener be built in earlier on in the visit? How often is it being given? And then, of course, the question that really ties into so many conversations that we have about health centers and addressing social risk factors is what services are available in the community, who is doing that connection. When something is identified as a point of concern, who's connecting those socially isolated patients with those resources and services. So again, a ton of great food for thought. I would encourage you to reflect on what your health centers or programs are currently doing to engage patients on this topic, and consider if there is anything else that can be baked in, or even if you're doing it informally, how then you're following up with resources once a concern is identified. So just really quickly, resources to stay connected, it's really going to depend on your communities. We have some links in the next slide that do speak to more federal programming, virtual resources that can be accessed from anywhere, but you are going to know your community best as far as what are the relevant and available home and community-based supports. So we're going to hear from panelists today that are talking about social clubs and a PACE model of care, both really unique ways to connect patients who could be experiencing social isolation and loneliness to their peers, to providers, but you are going to know best what's in your area. Area agencies on aging are such a great resource, and I encourage, if you are in an area where there's one nearby, to make sure you're familiar with their programming, as they can do a lot of supplementing of some of those social needs for those patients. We don't have the time today to dive too deeply into technology, but do want to mention it, as sometimes we assume that older adults don't use technology, and many might struggle with it if there's less technological literacy or less access. Certainly want to be mindful of ability to connect to the internet, the ability to navigate a device. But for those who feel comfortable or who are able to get assistance with using them, that is a great way to stay connected with others, as well as assistive devices. Again, if there's concerns with mobility, hearing, vision, ensuring that a patient has a device that's supporting them in that area can help make sure there's limited barriers to connecting as they normally would with their peers and family. And then volunteer opportunities, if those are available in your community, I would encourage you to make sure your older patients are aware of those. There are some virtual opportunities too, especially since the past few years, so much has shifted to online programming. So that can be a great way to give a sense of purpose, maintain connection to the community. And I just want to mention, I know we have a few comments in the chat, and of course, keep them coming. Yes, I completely agree with the comment that social isolation and loneliness is certainly not limited to older adults only. It really does require attention across the board. And today we just get the opportunity to talk about that unique intersection of those over the age of 65 living in public housing. But we can really see with some of this level setting information, and then going forward with how health centers can help keep patients connected, there could be other ways that could be replicated for younger patients or those living with multiple chronic conditions or other limitations where they're experiencing that. So I appreciate that. I also want to note, I did see the comment around how unsafe neighborhoods can really increase levels of social isolation and loneliness, and totally understand that. So here we're talking about what's available in your community. For some, there might not be much. So acknowledging that and wanting to work with the community partners that you have to be creative in how a patient's social needs are being met. So again, I mentioned we have links here. These are all national. Actually, we have a California one, I think, that was developed during the pandemic around more virtual opportunity to stay connected. Our center has a general guide around this that has the other links also in it under the resources. So if you are interested, if this is something where you haven't seen some of the national level resources or guidance available, feel free to take a look at these links when you get this slide. These are ways to either provide information to patients or to see what's available for you as a provider in how you're engaging them. So without further ado, we are going to move into, I think, the most exciting part of the session, which is really getting to see examples from the community. So we have East Coast and West Coast representation. Here today, we have two panelists that are going to be talking about their programming within a health center context. I'm going to let them introduce themselves. in more detail, but I'll say that our first panelist, Christine Pajarillo, is the Vice President of Programs and Social Services at the Whittier Street Health Center, which is located near me in Boston, Massachusetts. And on the other side of the country, we have Diana Aguiar-Braceno, who's the Housing Partnerships Manager at the San Diego PACE, so Program of All-Inclusive Care of the Elderly, which is connected to San Ysidro Health Center in San Diego, California. So we are so appreciative of their time and expertise. What we're going to do is have both of them present one after the other, and we'll have some time for audience questions. If you have questions or feedback during their presentations, feel free to put that in the Q&A or the chat box. And again, we'll have some time for discussion later. So Christine, I'm going to have you take it away.
Thank you, Ariel, and hello, everyone. I'm delighted to be here. As Ariel mentioned, my name is Christine Pajarillo. I am the Vice President of Programs and Social Services at Whittier Street Health Center. I've been at Whittier for 17 years. I started here as a behavioral health clinician, and I still am active in seeing patients along with designing some of our programs. To give you a little history of Whittier Street, Ariel, I'll have the next slide, I think, which will show our mission. Whittier Street Health Center is a Joint Commission accredited urban community health center in Roxbury, Mass. The health center is located in the densest area of public housing homes in Boston, with 17 housing developments within 1 mile. And Ariel, I believe this may be on the demographics, maybe on the next page, I'm sorry. Whittier's patient population is 43% Latinx, 42% African-American, and low income. 92% live below the 200% of the poverty level, and 82% live in public housing. More than 20% of our patients are aged 65 and older. Whittier's mission is to serve as a center of excellence that provides high quality and accessible healthcare and social services that achieve health equity, social justice, and the economic well-being of our diverse patient populations. Whittier was founded in 1933 as a well baby clinic. We initially focused on women's health, but in the years since, we've expanded its services to more than 40 different programs. And in 2012, Whittier opened its newly constructed health facility at 1290 Tremont Street in Roxbury. I'm emphasizing our address because that comes in handy later when I describe our club. But in addition to expanded medical and behavioral health services, our new building provides ample space for the whole person and holistic care, including a community education room for community events and educational sessions, and an expanded and affordable eye care dispensary, expanded oral health services to meet the increasing demand, and an on-site 340B pharmacy with discounted medications. We have specialized clinics to address wellness and the chronic diseases prevalent in the patient population. Whittier provides healthcare services to 30,000 patients and annually provides approximately 20,000 community education and outreach visits. These visits are conducted by our community health workers. We do a lot of work with our public housing partners, and we are able to do coffee hours and really do programming in the housing development. But the program I'm going to talk to you today about is our Club 1290. Throughout the pandemic, the needs of seniors remained a priority focus area for Whittier. As patient reports of isolation, depression, fear of COVID, bereavement, and loss were prevalent across all medical and specialty departments throughout the pandemic. Social isolation was reported at an alarmingly high rate by our senior patients as COVID-19 impacted the communities of color in Whittier service area at disproportionate rates, Throughout the pandemic, Whittier has been intentional with the design and delivery of all of our senior programs and events. We conduct turkey giveaways. We had designated hours for our senior population. We still continued our senior holiday celebration with social distancing. We did a winter clothing giveaway to really, again, still try to meet the non-medical needs of our senior population and the other populations in the health center. But as the turnout for these events. It was an overwhelming response from the seniors at each event. It really demonstrated the demand for more services focused on the needs of seniors. And here is Club 1290. Club 1290 launched in June of 2021 and quickly grew from 4 participants to the current enrollment of 19 members and growing. Club 1290 members represent an underserved community of racially and ethnically diverse older adults of color. Current participants of Club 1290 learned of the program because of word of mouth solicitation and from its existing members. So we really had to do minimal promotion here at the health center. Friends would bring friends, family members, and so it very quickly grew. We have minimal barriers to enrollment or participation. We are open to ages 60 and up. Most of our members are patients, but we're not having that as we don't have that as a requirement. Current group ages range from 60 to 97. To identify the specific needs of Club 1290 members, surveys were administered at the initial group session and to new members who joined afterwards. Needs of the group have also surfaced organically during meetings via open participation and discussion among participants. The Club 1290 meetings, including its structured activities, invited guest speakers, and workshop topics, have all been tailored to meet the identified needs of its members. One thing that I believe, and I'm sorry, Ariel, I may have gone off. I think the most descriptive way to communicate who Club 1290 is through its mission statement, which the club came up with on their own. We are senior adults who have come together to intermingle after the hiatus caused by COVID-19. Our purposes are directed at improving our overall health, having fun, fellowship, pursuing happiness and enjoyment. We share a mutual belief in social justice. We will actively and mindfully pursue happiness for ourselves and our members. We will help one another to shake off the depression brought on by the pandemic and start living life renewed. I think that's the best way to really describe who this group is. We've been very clear that we promote this as a club and not a therapy group. We are aware of stigma in some of the communities around mental health and seeking treatment. So we very much approach this as a social club, and I think it's really been effective in our community. We emphasize, as far as the activities of the group, we very much emphasize the importance of doing this group with our senior members and not for our senior members. So we promote autonomy, independence, and respect for all of our members. Some of the activities that we do, this is a bi-month, every 2 weeks, the group shows up at the health center. It is held on site at the health center. In the winter months, we are transitioning to once a month, but we do activities using resources from the health center. We have medical presenters, we have behavioral health presenters, eye care, oral health care, some outside resources that we've had to find through some of our existing partners include chair massage, line dancing, and Tai Chi. So again, there's a level of activity that that we're able to have everyone participate at some level, which is wonderful. And prior to receiving funding from the Creating Community and Reducing Social Isolation grant from the Boston Age Strong Commission, the group was really sustained from its members and from in-kind support from the health center, the space, coffee and donuts, but the group really wanted to have birthday cakes for one another. So they would contribute what they could, $1 for a card. Again, when we talk about dues, we are not expecting them to support fully the group, but now that we have the support from this grant funding, it's been wonderful to see our expanded abilities. We have the ability to spend in the areas of transportation, entertainment, and food insecurity. And one of the first things, we received this award at the beginning of this fiscal year, and one of the first things the members wanted to do was go to the movies and see the premiere of Jurassic Park, the new Jurassic Park movie. So we took 17 of our members to the movies and had the popcorn and everything. And it was a nice kickoff to our grant. But I definitely am thankful for the opportunity to talk about this group, but I definitely cannot take credit for the design of this group. I fully support it as the VP of Programs and Social Services, but the group itself, I think we've been very fortunate to have active members who are really buying into the belief that they can make this group what they want it to be. And so we support that and respect that. And I thank everyone for their time, and forgive my stumbling throughout this. I was a little nervous, but thank you to everybody.
No, Christine, that's great. Before we move to Diana's content, I think that Juliet's going to put a link in the chat. Maybe it might take a minute because I want to find it. I think it's such a fascinating thing for your health center. You already were focusing on this as a social opportunity for your older patients, but there was like city level support eventually, which I think is really interesting. You already mentioned the Age Strong Commission for the city of Boston, but I find it such an interesting model, knowing that it might not be able to be as easily replicated in some areas, depending on city budgets and all of that. But again, we'll put a link in the chat when we can find it, but there was many grantees from this initiative, all with the point of reducing social isolation. So really find that fascinating, and so glad that Whittier Street was able just to really enhance of what they were already doing. And I know we talked about this already, but I see some appreciation for the mission statement in the chat, and just in general, your view of the members of your club. Just see it so lovely how it's focused on really respect and empathy for them as individuals. And it's not just, oh, here's a service for you, but here's something that that you're involved in and you're helping to lead. And that's such a wonderful, empowering mindset. So thank you so much. If folks have questions, we're going to circle back again in the Q&A, but just want to mention that and how unique it was for that city and health center connection here. So without further ado, we're going to have Diana present around the PACE programming and housing partnerships. So take it away, Diana.
Hi, everyone. So like Ariel said, I'm Diana Yerbiseño. I work for San Diego PACE, and our sister company is San Isidro Health, which is our family health center, a clinic. And so PACE, the Program of All-Inclusive Care for the Elderly, basically the basic requirements for our program across the board is to be 55 years of age, certified by the state of California as needing a higher level of care, which means that every assessment that we do for anybody that's interested in the program, we need to do it's about a 2-hour assessment. It's conducted by an enrollment specialist, a master of social work, and a registered nurse. So these 3 staff members are the ones that do the assessment. They create a level of care, which then gets submitted to the state. The state nurse is the one that then gives us a yes or a no, approving that higher level of care. So we are not the ones that make that decision, but we do create that level of care, and then it's certified again by the state because they're the ones who give us that approval. So then they also need to be able to live safely and independently in the community with the help of PACE services and live within the PACE covered zip code. There are more PACE programs in San Diego County. There are 4. So there's St. Paul's PACE, Gary and Mary West, and then Family Health Centers PACE. And of course, us. So that, that can create some confusion. We are allowed to use the word PACE because that's the program by the state that we applied for. And so we can all use that. But, what makes us different is which, what's your brand, right? So we are San Diego PACE, and then, you have your other ones. So each one has, their strengths and how long they've been in the city. But for now, what makes us, I believe, one of the strongest ones here in the county is that our sister company is an FQHC, and that's San Isidro Health. So we have clinics throughout the county, and so even the doctors, that are in serving our communities, our low-income population, people without social security numbers. They're the ones who sometimes tell us, you know what, this person, I think they need a little more support, and they refer them over to San Diego PACE, because they know that we can have that focus for those people who are 55 years and older, and we can create, that coordination of care that's going to help them comply to their appointments. We have transportation. We have companions, for those seniors who are alone, who don't have anybody to go with them, or family members that are working. So then they will be the ones that, can go with them to doctor appointments. And then our biggest thing is the whole coordination of care. So they call one line, they call one phone line. From that phone line, it's your access to care. They can coordinate appointments to specialists, coordinate the transportation, coordinate the follow-up with the primary care doctor. And that way those seniors don't have to be calling this person and the other person and the other person. So that's just a little bit of, what the perks of the program. But we want to make sure that we give them all the tools that they need so that they can be safe and independent at home. So we'll go to the next one. Now, the newest thing in San Diego PACE is our housing partnerships. So collaboration brings quality care to your residents. And so we work and we partner with, low-income housing within San Diego. So the housing department, we have two. So I'm working in the marketing and enrollment, and we have a service coordinator on staff. Then we also have a clinical team, which is our housing navigation and our MSW. And of course, a CNA that can be on site, come on site. We have, your caregivers that come on site. So all of that is your clinical. So the way we work, we've now dived into permanent supportive housing. And so that needs, we all know that permanent supportive housing means, you need a lot of support so that they can stay housed. It's not easy. And so especially for people who may not have been, in good health, or not used to being, taking care of medical appointments and having to go here and there. And so our clinical team is huge for this because we're able to bring, staff to the site. So we're able to come into the site and even offer, the marriage and family therapists on site, substance abuse counselors on site. And that goes a long way. We're talking about sometimes seniors, especially with COVID, they don't want to go to the clinic. They're scared. They feel that if they go to a clinic, they're just going to go sick. But at the same time, it's again a mentality of, if I don't go, I don't get diagnosed, and it's not happening, right? And so by coming on site and bringing services to them, it makes them a little more keen of being curious about, well, let me go check what's this about, And so we offer this service, we're there Monday to Friday, 8 to 5. And so it goes a long way. And so with that, being on site with our PACE service coordinator, we're able to do activities, simple activities. We can do a little bit of bingo and mental health courses. We've done seminars on site for mental health. And, it's whoever comes. We know, especially post-COVID, that not a lot of people may come. Maybe nobody's going to show up. But we're offering a service, and here and there, we do have people that do show up. And so even some of our partners, have been surprised that certain, residents that they have in their community are coming out, and they hadn't been out in a while. They hadn't seen them in a while. And so, different topics is going to attract different populations. And so we don't give up, we don't just do it to be there and get them to enroll in our program. We'll also do it because of the partnerships we have, the populations we're serving. If they don't want to enroll in PACE, that's perfectly fine. They can still be a part of the service. They can still be part of the mental health series, the nutrition classes, whatever it is that is of their interest. But it's opening a door. It's opening, creating a trust. It's letting them know, hey, we're here. Feel free to give us a call, ask us anything, or don't, But slowly with that relationship and being on site with the activities, sometimes providing meals, or it sometimes seems that some participants, that's what we call our residents participants, they'll see that, you know, an LVN or a registered nurse coming to their home, or, you know, a caregiver, and it makes them like, I could help them, but how do I do that? And so it goes a long way being at a housing site, because these people tend to be protective. They, you know, there's a lot of scams for seniors. We all know that. And so, or families that may be taking care of their senior members of the family, but they have to go to work. So sometimes them seeing like, hey, there's a senior day center that they can go to. Let me go ask them, you know, or that'll help alleviate that 8 to 5 that they may have to go to work. Their family member can have breakfast, can have lunch at the senior day center. They can be showered, they can be taken care of, and they're not home alone, you know, at risk of falling or not eating or putting a fire in the kitchen. We never know. It all depends. But being on site just goes a very long way with family, with the service coordinators, and even property management. They've learned to also, you know, when they're having issues with hoarding, they know we have social workers, we have therapists. So they've learned that, you know, let me talk to them and see what services, you know, we can work out. So it goes a long way being there on site. With our first, when we developed the housing department, we didn't really see how it was going to go, but we saw the need. We saw the need, and we made it a focus, and we created a department just for it. So like I said, with COVID came food distributions. So there was a lot of no more events, no more things going on. And so we just said, well, how can we help? We're here to serve our seniors, serve the community. So we were, if they needed help, we were running to food banks, creating bags, doing deliveries door to door, making sure that the seniors were taken care of. So again, this is the huge benefit of our program. We're not scared to dive in and to just help, like I said. And so also those partners know that they can reach out to us because they know that we're not just there to market our service, but we're there to serve. And we can go to the next one. So these pictures here in particular are the mental health series that we did. This was just about 3 months ago. And so we did it at different sites. So as you see here, there's one slide where we only have three seniors at one, and the other ones we did have larger groups. So in these series, at these particular properties, they were not just one day. They were a 3-day mental health series conducted by our social work supervisor. And so the first day was a little rough, you know, only 1 or 2 came out. And then the next day there was more. And then at the end of the 3-day, there was a lot more. And so it was good, you know, that says a lot. You know, it's they talk to their residents, they communicate with each other, and they brought them out to the community rooms. And so that's good. We're trying to help bring a community back, especially, you know, we know the holidays are coming. It creates even more of an isolation. And so that's why we work directly with our social worker supervisor and try to address, you know, different ways that we can help the communities. And then also we do mobile clinics. So we use our San Ysidro Health mobile clinics. We go to the sites. Again, this has been during COVID towards the end or post-COVID to bring in resources to them. You know, we brought in LVN, we did blood pressure checks, we could do vaccination clinics. So we think outside of the box, again, with the support of our sister clinic, which is the San Ysidro Health, to make sure that we can service, you know, not only just, you know, you're 55 and older, but with the help of our SYH, which is San Ysidro Health, we were able to serve a little bit more of the community, and that helped a lot. Created a lot of interest and a lot of, can you come back? Can you come back? Because I want to tell my family. And so it was good. But again, it was diving into a community that we didn't know how it was going to work because of COVID. Things changed. We didn't know how they were going to take. People were scared. And so by bringing services to them, we found that there was more interest than having them go to our clinics. And that's pretty much it. And then if you have any questions, there's my email and my direct contact phone number. That's it.
Great. Thank you so much, Diana. I think we have There was a question early on when you were talking about assessment. I'm pretty sure around like generally assessing if someone is eligible for PACE. There was a question around what type of assessment is done. I believe that was when you were originally talking about.
So the assessment is done by a registered nurse, the social worker, and an enrollment specialist who conducts all of the paperwork. And so the appointment is 2 hours, about 2 hours, and it's either conducted on the phone or in person. It depends on the needs. Sometimes they request, the registered nurse or the social worker to come out, but the enrollment specialist is always on site at the house. And then depending on the need is how we do it. So the assessment, when this is conducted, they've already had a phone conversation with this person. The person has agreed to schedule this appointment. And that's how, we come to the site and, give them all of that. But prior to that, they already had a conversation about what is, their interest in the program, any questions that they have, especially with having to switch over to our health insurance. They have to give up their primary care doctor. So it's letting them know that, making sure that, there's nothing hidden within that, making sure that if they have any specialty care, sometimes because, again, we have our sister company, San Ysidro Health, we may have already a lot of the specialty care under contract. Sometimes they're able to keep that. And that is what, wins them over because that, I want to keep my cardiologist. So that's the initial assessment questions, appointments, medications that get conducted.
Great. And I will say I can have Juliet or Tiff plug it in the chat. If the mention of PACE, so programs of all-inclusive care for the elderly, if that's something that has kind of piqued your interest, if that's not something you've learned a lot about before, or you are interested in learning more about how health centers can provide this type of model of care to their older patients, we are going to host a webinar in late January, which is crazy to think that's next month. Next month, we will have, on January 26th, we have a webinar on PACE around expanding health center services to the older population through PACE. It's going to be more of a conversation around the benefits to patients, a little bit less than implementation, but we will have some information from the National Association for Community Health Centers, who will be able to give a little bit more resources there. So just a plug if folks are interested in learning more about PACE. We still have a few minutes if there are other questions. I wanted to ask you, Christine, around older patients at Whittier. I know you and I have had this conversation already, but I'd love for you to explain to folks kind of just how, I know you said that the club 1290 is expanding through word of mouth, but as far as interactions of providers or staff with older patients, how is it just through conversation? Is it more informal, that kind of social isolation or loneliness concerns are identified and then they're told about the programming? Can you walk us through a little bit about what that looks like at your health center?
Sure. We do a social determinants of health screening at medical appointments, an SDOH screening called Thrive. I don't know if it's something that's readily available to everyone. We do use the EPIC, our electronic medical record is EPIC, so it's one of the screeners in our electronic medical record. So we do a social determinant of health screening at all patient visits here. And so, yes, that's how conversation comes up about any types of needs or resources that a patient may present with. We're very lucky that, again, Whittier is not just a medical center. We do really emphasize the programs and the social services. So when food insecurity comes up, we have a food pantry here we can refer people to. When social isolation comes up in our older adults, we talk about Club 1290. We have other types of groups and services for other age groups, but that is the one that's more of a, again, it doesn't come as like a prescription, a medical like order. They really let people know that you're welcome to drop in. They emphasize that it's a club, and they all the providers are aware of sort of the purpose and the activities of the group.
Awesome. Thank you. So if questions come up for anyone in the live audience or watching the recording, feel free to pass them along to us. Again, you'll get an email from our center, the National Center for Equitable Care for Elders, soon after this session. we really would love if you take just a moment to fill out a quick evaluation, not just for saying, great, good job, but to say, hey, I want to learn about this other topic in the future. That really helps us to shape our future activities. We're so appreciative of Christine and Diana's time today in sharing about their programming and the ways that they are addressing social isolation concerns in older populations, especially those living in public housing. We hope that you'll join us again for future learning activities. We are always here for support. Again, we'd love to hear from you, and we thank everyone for your time today. Take good care.
Thank you.
Bye. Thank you.